All right, welcome to our masterclass on total intravenous anesthesia, or TIVA. Today, we're going to pull back the curtain on the science behind one of the most powerful duos in the game, propofol and remifentanil. TIVA presents this fundamental challenge. It's kind of like being asked to fly a jumbo jet, but you're not allowed to look at the engines. You're controlling the depth of anesthesia, but you can't directly measure the drug concentration in the one place that matters most, the brain. So how in the world do we fly blind? Well, let's get right into it and start with the foundational blueprint, the architecture that every single TIVA model is built on. The truth is, we don't fly blind at all. We use a map, and that map is called pharmacokinetics. It uses these really sophisticated mathematical models to predict exactly where our drugs are and where they're headed at any given moment. It's our GPS for anesthesia. And this right here, this is the core concept of that map, the three-compartment model. Honestly, the easiest way to wrap your head around this is to picture the body as a series of interconnected tanks. We fill the first one up, and from there, the drug just flows to the others. Now, what's really cool is how this breaks down. So the drug first hits V1, right? That's the central compartment. Think brain, heart, the good stuff. Then it quickly starts distributing out to V2, which is our muscles, and then a bit more slowly into V3, our fat tissues. But all the while, the body's actively working to get rid of the drug from V1, and we call that process clearance.
Okay, so knowing the drug is in the blood, that V1 compartment, that's great, but it's not enough. To actually get anesthesia, we have to get it into the brain. So let's see how the models handle that critical step.
So we call our final destination the effect site. Now, you can think of this as a theoretical fourth compartment that basically is the brain tissue. And here's the crucial part. There's always a delay, a time lag, for the drug to get from the blood, cross the blood-brain barrier, and actually get there. That time lag, well, it's quantified by a value we call KE0. Think of it like the efficiency of the border crossing at the blood-brain barrier. A higher KE0 means the drug gets its passport stamped and crosses into the brain much, much faster. That translates to a quicker onset of effect. Simple as that. Now, this gives us two really powerful strategies for our TCI pumps. First, we can target the plasma level, or CP. That's kind of like the tortoise in the race, a slow, steady approach that gradually raises the brain concentration. Or we can target the effect site, CE, and that's the rocket. The pump gives a massive initial front-end bolus to just blast past that time lag and get the brain concentration to our target almost instantly. So here's the deal. Different mathematical models, different algorithms, they calculate these doses in completely different ways. Let's start with our hypnotic, propofol, the drug that puts you to sleep, and see how this actually plays out. The two big ones you'll see are Marsh and Schneider. And just look at this table. You can see right away they're built on totally different assumptions. Marsh is pretty simple. It only uses total body weight. But Schneider? It's much more detailed. It takes into account age, height, weight, and it calculates lean body mass. And look at how different their assumptions are for that central volume, V1, and the speed to the brain, KEO. The real high-yield takeaway here is Schneider's use of lean body mass, which is usually calculated with something called the James equation. Now, why does this matter so much? Well, it's because drug distribution doesn't just scale up perfectly with total weight, especially when you have patients who are very obese or very thin. Schneider is trying to build a much more personalized model. But hey, propofol rarely flies solo. To handle pain and blunt that whole surgical stress response, we need its perfect partner. So let's complete our TIVA-DIVA duo and bring in the ultra-potent, ultra-short-acting opioid, remifentanil. Remifentanil is without a doubt a TIVA superstar. I mean, it wears off incredibly fast. We're talking just 3 to 4 minutes. Its breakdown has nothing to do with kidney or liver function, which is amazing. And the kicker? It works synergistically with propofol. That means when Remi is on board, you need way less propofol to get the same deep level of anesthesia. And when we talk about remifentanil, there is really only one definitive algorithm that everyone relies on, the Minto model, which was developed by the brilliant Dr. Charles Minto and his team. And you'll notice a pattern here. Just like the Schneider model for propofol, the Minto model is super sophisticated. It's not just looking at total weight. It incorporates the patient's age and their lean body mass. This isn't just about a different calculation. It's a philosophical shift toward a much more tailored, predictable anesthetic for every single patient. So we have these different models, right? Marsh, Schneider, Minto. But does picking one over the other, especially for propofol, actually make a real difference in the OR? Well, there's a fascinating study that involved underweight patients, and it gives us a crystal clear answer.
So, researchers started noticing that underweight patients, say with Crohn's disease, when they were managed with the Marsh model, they just consistently seemed too light. They were needing more rescue midazolam and higher doses of remifentanil just to keep their anesthesia deep enough. Something was off.
And the reason why, it all comes down to this one fundamental equation. To hold a steady target concentration, the pump's infusion rate has to match the patient's drug clearance. So if the model gets the clearance wrong, the infusion rate is going to be wrong, period. And this chart illustrates the problem perfectly. When the researchers ran simulations for a hypothetical underweight patient, they found something striking. The Schneider model calculated a significantly higher drug clearance than the Marsh model did. And that was the aha moment. The Marsh model, because it was underestimating the true clearance in these patients, was telling the pump to run a lower infusion rate. It was systematically, predictably underdosing them. This wasn't some fluke, it was a direct clinical problem caused by picking the wrong algorithm for the patient. You see, really understanding the architecture of these models, how they're built, what assumptions they make, it transforms us from just being people who push buttons on a pump to clinicians making precise, evidence-based decisions. So this brings me to a final thought. The next time you set up your TCI, ask yourself, given the patient right there in front of you, are you choosing the algorithm or are you letting the algorithm choose for you?